There are so many wonderful aspects to being 50 plus. We're wiser, bolder, and more in the driver's seat of our lives than ever. But when it comes to menopause, we can't overlook the impact that it can have in our well-being, our relationships, and in general, just how we feel. Do you have vaginal dryness, can't sleep, low libido, or brain fog? Today's show is empowering with information and tools to make menopause way more manageable. Health, wellness, career, family, life, and the better side of 50. I'm your host, Michelle Folan, and this is Asking for a Friend. Welcome, listeners. Today's guest expert is Dr. Somi Javaid. She is a board-certified OBGYN, leading women's sexual health care provider, and thought leader. She is also the founder and chief medical officer of HerMD. Dr. Javaid is a champion for women's health care and female-focused research studies. She's been a speaker for various health and wellness campaigns and events and podcasts, including where she spoke on gender bias and the female sexual health revolution on the TEDx main stage. Quite impressive, I must say. Through all of her work, she remains focused on her mission to educate, advocate, and empower women. Welcome, Dr. Javaid.
Thank you so much for having me.
Pleasure to have you today. I want to start things off with a little bit more about your educational background and how you got started on the path of women's health and advocacy, because I believe there is a personal story that ties this all together.
Doesn't it always start that way? It always starts with a personal story, right? And an aha moment. I was pre-med at the time, so I already knew I loved science and math and thought I was going to go into medical school. It was a phone call that I received when I was pre-med at Northwestern. And I picked up the phone and I heard, "Somi, you need to come home." And I got goosebumps because it was my father. I had known that my mom had been in and out of the hospital the previous 6 weeks, complaining of left arm pain, shortness of breath, chest pain. She was 45 at the time, thin, non-smoker. So no one was thinking it was her heart. But I think now if we Googled her symptoms, everyone would think it's her heart. We have a very strong family history of cardiovascular disease and death in women, but her doctors just wouldn't take her seriously. They kept dismissing her. And frankly, data and science at the time couldn't explain why thin, non-smoking young woman would ever present with four-vessel disease. And that's exactly what happened to my mother. She had finally gone for confirmatory testing via cardiac catheterization. You know, that's where they put dye in your vessels to see if there's blockages to your heart. And she had a 95% blockage of what they call the widowmaker, or the main artery to the heart. And so she became profoundly unstable during her testing and actually got taken for emergent quadruple bypass surgery. And so at this point, what the medical community had done was robbed us of that time with my mother that I would have loved in the pre-op area, to meet the surgeon, to ask questions, to give her a hug, tell her I loved her, because you don't know if someone's going to make it out of surgery. And the next time I got to see my mother, she was being wheeled out of surgery, obviously unconscious, sedated. And thankfully, she's alive and well to this day. But her medical experience nearly cost her life. To me, it was a very teachable moment once I got over the shock of everything. Was I am going to go into medicine, but I'm going to be an advocate for women. And so I went on very traditionally, went to medical school and residency and got my first job. And then the reality of our healthcare system for women smacked me in my idealistic face as I was trying to be an advocate and a champion for women when I was seeing 50 patients a day and frankly didn't have time to go to lunch or even go to the bathroom. After a couple of years of seeing patients in these type of environments, I was a university professor for a while, I was private practice for a while, I just could not find the space to practice medicine the way that I had set out to practice medicine and the way that we know women deserve care. And so just shy of my 40th birthday, I told my husband the scariest words in the English language. I have an idea. He will tell you those are the scariest words. And I bought a building and I opened HerMD. And the mission was to educate and empower women to talk about all things that were previously stigma, taboo, and to make them comfortable and to focus on the whole woman, talk about all the things that may affect their healthcare and do it so in a very, very beautiful, warm, welcoming space. And here we are 7 years later with 2 locations, many more on the way, and with a concrete plan to expand this care nationwide.
Fantastic. I love your story. And this is precisely the audience that needs to hear this story. So when we talk about women who are 50 plus, the first thing we think about is perimenopause and menopause and everything that is happening in our world. I was wondering if you could define perimenopause and menopause, the symptoms, because I think people get them a little confused.
They do. So the average age of menopause, let's start there first, in the United States is about 51 years young. How is menopause defined in the medical community? One of 2 ways. It's either 12 consecutive months with no bleeding. Once you've gone 12 months without a menstrual cycle, we can consider you menopausal. And you're like, well, why is there another definition? Well, some women have had a partial hysterectomy or they've had a procedure where they don't have cycles anymore, not because their hormones have changed, but because we've modified their uterus or their reproductive anatomy. The other definition is an elevated FSH, which is the menopause hormone. It stands for follicular stimulating hormone. If that's elevated on 2 occasions, usually greater than 30 in our labs in the United States, then we can also consider a patient menopausal. What is perimenopause? Perimenopause can be up to a decade long. For most patients, it's not. That's the longest, where women can present with all of the symptoms of menopause, except for the lack of bleeding part. Most women in perimenopause are still menstruating, maybe not monthly, maybe every other month, maybe quarterly, however it is. It starts to become very abnormal. So that's the distinct difference between perimenopause and menopause. You should not be bleeding in menopause anymore. The rest of the symptoms can all be the same. And I think this is the aha, mind-blowing moment for most women. They think hot flashes, insomnia, and that's it. And when I tell them that menopause can affect us from head to toe with things like changes in anxiety and depression and mood, mild cognitive decline, so going into your pantry, forgetting why you went there in the first place.
Oh my God.
Or feeling like you're not as sharp. We all read that headline, 900,000 women in the UK left the workforce because they weren't feeling like their best selves at work anymore and they felt like they weren't getting the help that they needed. Breast changes, either lack of sensitivity or more sensitivity, weight gain, particularly in the midsection. So women start to complain about their body changing, the shape changing. So they start to complain about more abdominal fat or feeling like they have a menopot is what they've said, a little pot belly.
Yeah. Oh, so that's what that is.
That's what that is. Dry skin, dry hair. They start to complain about accelerated aging, more wrinkles or age spots, dryness in the joints. And all of this is because estrogen is very hydrophilic. It pulls water with it, along with, feeling dryness in our skin and our joints and our hair. That's where some of those vaginal symptoms start to occur. And we call the collective symptoms that we get in the vagina genitourinary syndrome of menopause, because it's not just limited to vaginal dryness or increased risk of infection, but also can cause some bladder changes, whether it's now losing urine when you're jumping on a trampoline, or you can't cheer on your kids anymore at sports events without worrying about having some loss of urine.
Right.
And yes. And then going along with those vaginal changes, there can be changes in the bedroom. And, oftentimes I talk about how menopause can affect you from bedroom to boardroom, because we talk about changes in orgasm. It may take longer or not happen at all. Problems with arousal, like your body's not responding. Problems with desire, not being in the mood anymore. Some of this can be hormonal and directly related to menopause. Some of it can be due to the anatomic changes. If women are telling me it hurts, of course they're not going to want to have sex. Nobody wants to do something that doesn't feel good. Why do most people like to eat ice cream or have sugar? Because it gives us euphoria in the brain. What I do is teaching women, hey, that's normal. You're not going to want to have sex if it hurts. So let's address that first. So that is just some of the symptoms that can occur in perimenopause and menopause. And so many women are not taught this by their providers. So many women are dismissed by their providers, and they're put on antidepressants instead of hormones. So those are some of the big changes. And then the invisible changes that I love to talk about are bone, brain, and heart. So I alluded to some of the brain changes, but we start to develop increased risk of cardiovascular disease because estrogen protects our vessels. So that's one of the hidden changes of menopause. And then women have the most rapid period of bone loss the 3 years after menopause. So it's like a nosedive off of a cliff. And so we need to intervene either with exercise, calcium, vitamin D, hormones. So those are the most important changes that occur clinically in menopause and perimenopause.
The premise of this podcast is also I'm asking questions for my friends, and I threw it out there to them that I was speaking to you today. You just checked off every single symptom. They said, I have no sexual desire. What should I do? Painful intercourse and dry skin, dry eye, brain fog. Is that fact or fiction? Is it just in my imagination? Energy loss. And then the big one was weight gain.
Mm-hmm.
I had several people ask about weight gain. Again, this goes back to the original discussion is if people are having all these symptoms and they're asking me to ask you, why aren't they asking their own healthcare provider? I want to advocate and empower women to do that. This is great. This is good stuff.
And a lot of it is, it's either been taboo, stigma, or shame. They had a negative interaction with a provider who may not have opened the door for them or frankly closed it for them. Sometimes I'm told, well, that's not polite to talk about, Dr. Javaid. Like, we never talked about it in our family. I think if you give women the avenue and the correct vocabulary and teach them and help them, it's pretty amazing. We've grown to over 7,000 patients at HerMD at our 2 locations. But I wanted to tell you the story of menopausal mice. This always goes over very well on podcasts and when I'm talking. But, that weight gain, patients are like, Dr. Javaid, I'm doing everything I've done my entire life. I've never had a weight problem. And now all of a sudden, I'm having weight gain. And I want women to get away from that blame mentality. Well, if I just push away or if I just work out more, it's just so harming to think about that way. And so I tell the story of menopausal mice. And please, people who are listening to this podcast, I'm not comparing you to a mouse, but I think this is a great story to help you understand what's going on. There's a study that was done creating menopausal mice. And so they took 2 subsets of mice, gave them the same grain and the same exercise wheel. And then one set was injected with that FSH, right? So they artificially made them have really high FSH levels, which I taught you all is menopause, right? Every single menopausal mouse became obese and the other ones did not. And so what happens is there are distinct changes in where we deposit fat after menopause and also what happens to our metabolism. It definitely slows down. So things like, no, you're not doomed to have a menopause or to continue to gain weight. Things like intermittent fasting can rev up that metabolism. Hormone replacement therapy, changing the way you work out. Women do need to either start toning, Pilates, weightlifting. We just need to approach it differently. It doesn't mean harder, faster, and starving yourself. It just means tricking our system so that we can get our metabolism back to where it was before we went into menopause.
It's so refreshing to get this kind of practical advice from an OBGYN. I just love it. When you say the body weight shifts, is that because our ovaries are no longer producing hormone and it shifts to the adrenal glands? What causes that?
So what's happening is as our estrogen and testosterone, so those are produced in our ovary, as those are declining, the FSH, which is released from the pituitary gland, starts to go up.
Okay.
And so when we have those high serum levels of FSH, it's kind of like going way back to Darwinian theory. Basically, we go from our reproductive years to being more of a hunter-gatherer, right? So we don't need more breast tissue. We don't need more hip volume. We're not childbearing anymore. Almost as if we were prepping for those long winters, right? And having all of that fat in our abdomen. Remember, fat has a purpose, right? It protects our organs and also is a source of warmth for us, right? We cannot have zero fat in our body. And so that's where we think that's coming from. But that's why I'm here to say, don't starve yourself and don't over exercise. There are things that you can do to kind of correct that pattern. I love intermittent fasting. Intermittent fasting controls our insulin levels. High insulin levels are not great. Causes weight gain, because what do we do with insulin? We take sugar out of our bloodstream so we don't become diabetic, right? We take sugar out of our bloodstream, but how do we store it? We store it as fat. And so if you continue to have high insulin levels with continual snacking and what we do normally with our American diet, it's not great. So even 12 hours of fasting, 14 I think is ideal for most women, and it's not that hard. I have started doing it myself for the last 2 or 3 years, but there's other benefits beyond your waistline. Lower insulin levels also decrease our risk of almost every single type of cancer there is, especially as women. I think that's very important. Also reduces our risk of cardiovascular disease and diabetes. And I like intermittent fasting because it's not a fad diet. It's not something you try for a month. It's a lifestyle. In fact, I think we should remove the word diet out of our vocabulary. I think it's very negative, and I think it places blame on patients.
Okay. If I am drinking coffee in the morning and I put a little bit of half and half in it, am I cheating on my intermittent fasting?
I am not an intermittent fasting expert, but what I've heard is no. If it's less than 30 calories and it doesn't have artificial sweeteners in it, because you can't just go by the caloric load, because if you have something sugary, right, your insulin levels will spike because your body is anticipating that it is getting sugar. So I've heard no, it's not. Now, I take my coffee black, which is a long way from where I came from my coffee drinking days. And so I take my coffee black. I do intermittent fast at least 4 or 5 times a week. And it's really helped me with my metabolism because I'm a perimenopausal patient as well. I'm not quite there yet with menopause, but I'll be 47 in a few weeks, and I'm definitely perimenopausal.
Got it. Well, let's talk about hormones and hormone therapy, because I think there's a lot of misinformation out there. And I want to talk a little bit about estrogen first, if that's okay. When do you test someone's estrogen levels, and at what level would you start treating someone with estrogen? And what considerations do you have to make in terms of past family history or past health history?
That's a really good question. We check hormone levels in the perimenopausal stage because I don't believe in making a woman go 12 months and be symptomatic and suffer. So if we can catch her in menopause in the 6th month of menopause, right, with the 2 FSH levels, we'll go ahead and treat. But ACOG, the American College of Obstetrics and Gynecology, standard of care is you do not start full-blown hormone replacement therapy until a patient is truly menopausal. There are other things you can do in perimenopause, but let's talk about true full-blown hormone replacement therapy. We go by FSH, not the estrogen. If the FSH is greater than 30 on 2 occasions, then we begin to treat. Estrogen levels typically for patients prior to menopause are up to 500. After menopause, they drop to less than 20. Our goal of therapy is a very narrow window, greater than 20, less than 100. So think about that. Even if we maximize you in menopause, we're still keeping you at a fifth of where you were, right, when you were not menopausal. Now, you're not 500 the whole time, right? Estrogen levels change throughout the cycle. That is the goal of therapy. Estrogens are offered in a multitude of different ways, right? Oral, transdermal, transvaginal, pellets. There's so many different therapies. My preferences are bioidentical. What does that mean? Not any chemically different than what your ovary was producing, and a single molecule of estrogen. Very different than something like conjugated, like Prempro or Premarin, derived from horse urine initially and has about 17 different molecules in it. Not very clean. So I love bioidentical. I love transdermal. So that's the preference. So either a patch or a spray or a gel, transdermals tend to be much safer than oral medications and have less adverse effects. So those are my preferences. And then if a woman has a uterus, because estrogens will stimulate the uterine lining, they need to be on some type of progesterone to protect their uterus from, frankly, uterine cancer. If a woman's in menopause and she has a uterus, she will get estrogen and progesterone. You asked a question about past medical history. So there's things that we look at. Strong family history of breast cancers or GYN cancers and cardiovascular disease. A patient should have a thorough history and physical with a medical provider. Pop-up hormone shops don't do that, right? And then the second thing is if you have strong family history, have you been offered genetic testing? And there's another test now available on the market that goes one step further than genetics. It's called Gallery. And it actually tests your blood for proteins that can check you for 70 different types of cancers, 50 of which they have no screening tests in the United States. So who would I offer this testing to? Someone who walks in who has negative genetic testing, but a very strong family history, but wants to go on hormones. There are two tests you can do there, the genetic testing and then the Gallery testing. And then someone who has very strong cardiovascular disease, like my family, or they have high cholesterol, you have to be very careful. So we send them for something called a coronary calcium score, which gives us their risk over the next 5 years of having a cardiac event and whether or not we can safely offer hormone replacement therapy. Women who've had a blood clot, stroke, uncontrolled blood pressure, aneurysms, things like that, they're not candidates for hormone replacement therapy. The risk of blood clot or event like that is just too great.
Okay. And if you start me on estrogen, so say I had a hysterectomy last year around this time. If you put me on estrogen, what am I going to notice first?
So everyone's different. It depends on what symptoms you're having. Most women will notice resolution of their hot flashes if they're having any first, and then they'll notice improvement in sleep. They'll start to notice either weight loss or dropping off of the weight gain they're experiencing. Their joints will start to feel better. Energy starts to feel better. Obviously, it's a combination of both the estrogen, but also the fact that they're sleeping better. Estrogen alone doesn't typically help with sex drive unless the lack of sex drive is because you're so tired and you're not sleeping. Lack of sex drive is something called hypoactive sexual desire disorder. It affects about 1 in 10 women in this country and is treated a multitude of ways. But those symptoms are what I will tell patients and what they tell me that they notice first. Typically, I tell patients about 8 weeks until they feel good on the dose that we picked. So then we meet again, we recheck levels, we see where they've gotten to, and then we review symptoms. And if they're good where they're at and they're between that 20 and 100, we leave them alone. If they are still having, they say, this is better, but this is not, then we may change the dose. And so that's how we work that at our offices. And a lot of people who do treat menopause, that's how they do it.
Okay. I will tell you, last week when I was on vacation, I didn't use my estrogen. I will never do that again because I got all off on my schedule and my normal routine being on vacation. And that was a big mistake. I'm getting back to normal again, but it takes a while. It's not going to happen overnight.
No, I tell patients estrogen's like a potent drug. And if you're used to caffeine every day and then you go out without it the next day, you don't feel good.
Mm-hmm.
If you're on estrogen and you skip your dose, you're not going to feel great. It's just like that. And when I explain that coffee analogy, people are like, aha, Dr. Javaid. I'm like, you got to stay on your medicine.
It makes so much sense. So I'd like to also talk about testosterone because this is a hot topic. Mm-hmm. Anything from creams to pellets. And what is your end goal with going on testosterone? So tell us, please, tell us more.
Ooh, this topic makes me so angry right now because every woman alive who has ovaries, because some people are born with anomalies, I understand, but every woman that is born with ovaries, we can all check our serum levels and we make testosterone. Just a few years ago, there was a global consensus statement that came out that's saying testosterone is needed and supports us in all the domains of sexuality, and I'll explain what that means. And it's also safe when they looked at risks of testosterone. But yet in this country, we have yet to develop even one product that is testosterone only, FDA approved for women. You heard me correctly. There is not even one FDA approved product that is testosterone only, despite all of this data, despite all of these consensus statements. And some of it is to be blamed with opportunistic providers who are pumping women full of testosterone and changing their voices and giving them beards and making them have all kinds of crazy outcomes. I've seen it all in my office because it's not regulated, because we don't have an FDA approved product. But for those of us in the know who specialize in sexual health care, testosterone is one of the best ways to treat women, as long as they're safe candidates, okay? But it helps with all the domains of sexuality. What do I mean by that? That is what the FDA and drug companies use to measure where a woman is in her sexuality. It's one of the only objective measures we have. And basically, it breaks down sex into all the different categories that a woman could have problems with: orgasm, pain, moisture, arousal, desire. And so it's a survey that women are given in offices like mine. But basically, testosterone has shown statistically significant improvement in all areas. And so how do those of us who treat women with testosterone, how do we get a hold of it? There are a couple different options. You can treat women with male products, tend to be very expensive because they're not covered by insurance because you're the wrong gender. And they're very difficult to titrate. Women need just the smallest amount of male product. So not a great option. Pellets are an option as long as they're done correctly. A pellet looks like a little Tic Tac. We put it underneath the skin in a very easy procedure in the office. And then they're put in about every 3 months, every 4 months. And then we can also prescribe creams. Creams usually come in a toppy click system where you turn it, you hear a click, and it dispenses the amount that you need. So I'm a big, big proponent of testosterone in the right patient and if the patient is comfortable, right? That's the other thing as providers. It's a partnership. If testosterone is not an option, either a patient cannot take hormone because of cancer or blood clot or heart attack or stroke, because testosterone is not without risk. It can cause some hair growth. It can definitely give you some acne. But most women, once they get through the adjustment phase, they feel amazing on testosterone. There are 2 FDA-approved medications currently for low sex drive in this country. One is Addyi and one is Vyleesi, and they both work on neurochemistry. They are both completely hormone-free, and they are FDA-approved for HSDD, hypoactive sexual desire disorder, or i.e. low libido.
Okay. So I was put on a very low dose of testosterone last year, and it really does help. Being monitored, all of that, family history, and I will say it does make a big difference. For me, it was my sleep. Mm-hmm. I think it really helped me with sleep, maybe in my head, but I did feel a difference once I did start on the testosterone.
I'm going to challenge you on that. It's so funny. Do you see what you just did? Because I didn't say it to you. You were like, well, maybe it's in my head. No, it's not in your head. You know your body better than anybody else. And I may be an expert, but this is what I tell my patients every day. I teach, but I also learn. And would you be surprised if I told you that every month I hear that someone says to me, I sleep so much better on testosterone. And I think biochemically, the way I can explain it is testosterone breaks down into estrogen. And so it may be that little bit of a bump in estrogen that's helping you sleep better. You are not the first person in 20 years of practice to say that to me too. And when my patients say that to me, I believe them. You're with yourself every day. I'm not. And so if it's helped your sleep, then just because it's not statistically proven or we haven't done a study yet, doesn't mean it's not true.
Well, you made a comment before about how frustrating it is for you that there hasn't been anything FDA approved for women with testosterone. How far away are we in getting there?
I've seen so many products almost get there. They're in phase 2. They're in this phase. I think a product is coming in the next 2 or 3 years. I do not think there is one on the pipeline for later this year. It's frankly taken way too long, especially when there's so many formulations already out there for men. And if you think about it, we just need the dosages corrected, and we need it obviously to be studied in women, because women currently in 2022 are still underrepresented in 3 out of every 4 clinical trials. We know the products that work. We know the formulations that are safe. We just need to adjust that dosing for women, and then we need to study it.
Okay. Any other hormones that can be part of the equation in treating menopause?
I mean, typically it's estrogen, some type of progesterone product, and testosterone. The only progesterone product we didn't talk about is sometimes some providers will use an IUD instead to protect the uterus, understanding that we're not doing it for pregnancy prevention. But if a woman doesn't tolerate progestin, sometimes progestins can cause weight gain, they can cause bloating, they can cause emotionality. And so patients will say, well, I want to stay on my estrogen, but I don't want this progesterone. And so sometimes an IUD will be prescribed. And in certain patients, it's not a bad idea.
Okay. I said earlier, one mission of this podcast is to encourage women to make their healthcare a priority, be advocates for themselves. Share your thoughts on how not only women should be speaking up, but what they should be looking for in their own health provider. What would you tell someone, say a friend came to you and say, my doctor's not really cutting it. What should they be looking for in a practice?
Women need to go into their doctor's offices prepared with questions. I think they'll get the most out of their appointment that way. But here's the bottom line. If you're asking about vaginal dryness or sexuality, and you can see that your provider is uncomfortable, that they have a hand on the doorknob, or they say something crazy to you like, drink some wine and you'll be fine, or what? You're still having sex? You're too old for that. Or I heard someone say once, I can't get my wife interested. How am I going to help you get interested? You need to run, not walk, but run. Ask friends about referrals. There are true great organizations, North American Menopause Society, NAMS, and also ISHWISH, which is the International Society for the Study of Women's Sexual Health. Maybe you can put links out to your listeners. Those two sites have Find a Provider. And so then you will get access to people who are trained both in menopause and sexual health care. And then it's just a matter of finding the right provider with the right bedside manner for you. You need to find a provider who is a partner in your healthcare, who listens to you. Because I may think something's great, but if a patient's like, I'm not going to do that, then that's not great for them, right? Despite whatever data or expertise I may have. You need to have a provider who will take the time, who listens to you, who advocates for you, and frankly has expertise in this area, because a lot of GYNs either do not have the training or simply do not have the time. Like if you would have come to me at my first job, you would have been very disappointed with our encounter. Because when I was seeing 50 patients a day, I can guarantee I was not talking about sexual health.
You didn't have time.
I didn't have time.
No. And, I had one friend mention that she utilizes her GYN as her primary care provider. What are your thoughts on that?
Don't do it.
Don't do it.
So here's the deal. I tell people, and then they get it. I go, would you let your cardiologist do your pap smear? They look at me like I have 10 heads. They're like, no. And they're like, Dr. Javaid, we love you so much. You listen, you spend time. Can you just manage this? And I'm like, no, that is not my board certification. That is not my expertise. I may not know the best treatment for you. So I don't mind being the quarterback, is what I tell them, like helping them facilitate, getting them in the hands of the best professional. But the way I go to work every single day is I would not do that to my mother, my sister, or my best friend. I'm not an internist, so I don't recommend that. We just don't have the training to adequately take care of those problems.
What do you mean? You don't want to treat my sinus infection? I know we're living longer than ever, right? And the meaning of this conversation is really to let women know that they don't have to live with the status quo for the next 30 years. This was an incredible conversation. I appreciate your honesty and your transparency, and it's so incredibly refreshing. So thank you so much. Do tell me where people can find you if they want to reach out and be a patient.
Yeah, so you can check us out at hermdhealth.com and become a patient either virtually or in person. You can check us out. We're always doing fun educational events that are free to patients on Instagram. We are now on TikTok, both Somi Javaid MD and HerMD Health. And that's where you can find us, and Facebook as well.
Great. And I'll put all that in the show notes so people can have access to that. Again, thank you so much for being here. This was great. And I have a feeling we're going to have to do round 2 because I think there's a whole lot to unpack here.
Thank you for having me. I love talking about this stuff.
Oh, thank you, Dr. Javaid. I appreciate it so much. Follow Asking for a Friend on social media outlets and provide a review and share this show wherever you get your podcasts. Reviews and sharing help us grow.